selecting the state when we did in the summer, we had no other conflicts. However, NCSL is having a 2020 post-election wrap-up right now. I'm sure many of you have seen that invitation, perhaps even registered. So I did want to let you know that'll run from 1 to 2:45 Eastern time. So when we end, you can certainly hop over to that and catch the better part. Also, that is being recorded, so you can watch it in its entirety once it is archived and on our website. Next slide, please. Thank you. And thank you to Riley, who is advancing slides. We had some tech snafus this morning, so thank you, Riley, to the rescue. So here's what I want to do with our time today. First, I want to go over a couple administrative details. Again, we are recording, and Jenny's going to pop in the chat for anyone that's interested, a location on NCSL's website where you can find the archive of this and all the other alumni series that you can watch at your pleasure. If you're on the line and if you're able to enable your video, we'd very much love to see your faces today, so I'd encourage you to do so. And then if you're also able to click on the 3 little dots at the top of the screen and update your name to perhaps reflect your title and your state, that would be helpful as well. After a few more brief comments, I'm going to talk a little bit about session 1, provide a little overview and recap. For some of you, I know that will be a reminder. For others, it might be new information. Next slide, please. Then we're going to do a couple poll questions. One, just to get some feedback about this series in general, and then 2 questions to kind of get us starting to think about the topic of the day, impact of racism on health equity. I'm going to then turn things over to 2 very special experts who are going to discuss the impact of racism on birth and early childhood health outcomes. So you'll be introduced to a useful tool, the State of Babies Yearbook, and you'll also hear from an NCSL colleague about policies and legislative activity at the state and federal level. We'll also have, excuse me, 2 opportunities to break into small groups to have some dialogue, and then we'll come back together to debrief as a full group. I'd be remiss to not send a big thank you to our generous sponsor. This session and the full series is made possible by a grant from the Buffett Early Childhood Fund. NCSL appreciates their financial support and partnership as we bring you this new series and programming to deepen your knowledge around race and equity and the early childhood system broadly. Next slide, please. So now just a little sort of context setting for today. Racial health disparities have long existed, seen that the COVID-19 pandemic has exacerbated this point. Today, we're really going to take a focus on the early years, but as you all know on the line, no child lives independent of a family or caregivers, and each of their health is inextricably linked. This pandemic has renewed calls to address racial inequities in health across the nation. In fact, a growing number of cities and states and counties have declared racism a public health crisis. In August, the Nevada legislature passed a resolution declaring systemic racism a public health crisis and urging to address it. Policymakers in a handful of states, including Arizona and California, Michigan, New Jersey, and Ohio, have also introduced similar legislation. And then states like New York and North Carolina have bills to establish commissions or task force to study the issue of racism. And most recently in Denver, their Department of Public Health and Environment released a statement recognizing racism as a public health crisis. I just think that that's important framing to have in the back of your mind as we continue today. Next slide, please. So as a quick refresher, let's look back at what we learned in session 1 this past September. The first session really laid the foundation for this 5-part series. And now this session and the next 3 sessions are going to focus more on policy solutions. So on September 24th, Dr. Rosemary Allen presented the historical context of racial inequities and disparities that affect families and young children of color. So through her presentation, we learned about and discussed such things as slavery and sharecropping, the Great Migration, and redlining. And we did this all by following a little boy and learning about his family through these and many other historical events. For those on the line, Dr. Allen shared that race is a social construct, classification of human beings that is politically defined. Dr. Allen also introduced us to Jamal, a young 5-year-old boy. And as we were introduced to Jamal, we followed his family history dating back to 1670, when his 6th great-grandfather was stolen from East Africa and enslaved in Louisiana. We actually learned a lot about the historical nature of racism in the US, and specifically about Jamal's history. And the rationale for doing this and introducing you to Jamal in session 1 was to try to personalize the entire series. So a potential way of creating a personal relationship and making the information shared perhaps more relatable for some. Between the start and end of this series, we'll continue to reflect on this little boy. You'll continue to hear his name and see his image as we proceed through May with our session. My NCSL colleagues and I welcome you to consider Jamal as you move through today's session on health equity and during the next 3 sessions, which all have a race and equity lens applied to the topics of family life through the early years, early care and education, young children, and the environment. And for those of you, if Jamal's story just doesn't resonate, that's perfectly fine. And we invite you to consider the young constituents in your district as you hear the information that we share today. Next slide, please. Okay, so I think that's enough information and framing, and it's now time to move into the session. So first and foremost, my colleagues and I want to learn from you, our NCSL Early Childhood Formally Learning Fellows, alumni. As you all know, we'll be hosting in-person, well, remote in-person, I suppose, sessions between now and May every other month. And what we're interested in knowing from each of you is on those off months, what, if anything, could we do to support you as policymakers? So my colleague Melissa is going to pop up a little poll that hopefully you'll see on your screen. And we're asking you to pick from 5 potential options. During the month, the Alumni Series does not offer a live session. I'm interested in engaging with fellow legislative colleagues and NCSL experts in an informal way through Zoom. So I'll give you all an opportunity to select which of those 5 responses feels best to you right now. And Melissa, do we have responses coming in?
Yep, they're coming in. We've got 17 out of 28 on the line. So we're about 40 seconds in. Yep, I don't know if you want to wait one more.
Let's wait one second.
Mm-hmm. Yeah, looks like things have slowed down a bit.
All right. Well, we'll call that good. So thank you. Okay, perfect. Thank you all so much for sharing some of your feedback. We can go to the next slide also, Riley. We've just sort of been interested, you know, how to stay engaged with you. Is it a newsletter? Is it a touch point? Is it something else? So thank you for doing that. And now the next 2 polls are going to get us thinking about the topic that we're going to discuss further today. So the first, or the second poll actually, that Melissa's going to pop up in front of you, asks you a question and you have 4 options on how to answer. If you want to launch the poll. The question is, the national average of maternal mortality occurs at the rate of 17 deaths for every 100,000 live births. But the rate of maternal mortality among Black women is greater. And we're asking you to select which of the following. And for other NCSL staff on the line, I'd encourage you, feel free to give your guess. The answers could be 21 deaths per 100,000 live deaths, 32, 40, or 49 deaths for every 100,000 live births. Responses coming in, Melissa?
Yep, we're about the same percentage as we were. It looks like there's still one or two trickling in. Okay.
Should we see what they say?
Yep, looks like things have slowed down.
All right. We've got some very smart people on the line. While it's a painful number to really say out loud, you all are correct. 40 deaths for every 100,000 live births. And then our final poll, and I should say those are points that we will hear more about today. And the final poll is a true-false question, and we're asking you to decide if you want to launch that poll. In a national poll, nearly 1/3 of Black Americans reported they had personally experienced racial discrimination during a visit with a healthcare provider. And we'll let you select whether you think that statement is true or false.
About half of people, a little over half, have voted. We'll wait till things slow down a bit. Okay, yeah, it's been quiet here for a second, so I think we can end this one.
Okay. And again, you guys are right. It's sad to see, but that is in fact a true statement. So thank you all for taking some time to do those polls. Riley, we can go to the next slide. Excuse me. So now I'm thrilled to introduce two dynamic presenters to you. Today we're joined we're joined with Dr. Myra Jones-Taylor and Ms. Kine Nguyen. And I'd invite you to read their full bios, which are available on NCSL's website. Jenny's gonna put in a link where you can learn more about these extremely intelligent presenters. I'll just say a few opening comments about them. Dr. Myra Jones-Taylor is the Chief Policy Officer at 0 to 3, and today she's joining us from Washington, DC. At 0 to 3, she leads the development and implementation of their policy agenda, priorities, and strategies. And she also oversees the Policy Center. And Ms. Kine Nguyen is a senior policy specialist in the health program here at NCSL, and she's joining us from Denver, Colorado. In this role, Kine manages the Maternal and Child Health Fellows Program and conducts policy research for maternal and child health topics. Dr. Jones-Taylor is going to walk through the second annual State of Babies yearbook, diving deeper into the good health plank. As you'll hear from Dr. Jones-Taylor, where children are born can affect their chances for a strong start in life. Babies need good health, strong families, and positive early learning experiences to foster their healthy brain development and help them realize their full potential. After we hear from Dr. Jones-Taylor, we're going to break out into small groups for a little dialogue, directions to follow. Then when we return, we're going to hear from my colleague, Kine Nguyen, and she's going to share some trends and legislative examples specifically related to reducing disparities in infant and maternal mortality, prenatal care, and COVID disparities. She also has some really useful resources to share with you all. I'd encourage you to share information in the chat, and when the time is appropriate, even unmute your line and join the conversation. We'll have one more breakout after Kine presents, and then we will be in the full group. My last point is hopefully all of you received a personal email from my colleague Riley Sawyer earlier this week, and that email should have had, or did have, an attachment of the 2020 State of Babies yearbook state profile for the state that you're calling from. If you didn't receive that, don't worry. Jenny just put in the chat where you can click and access the yearbook and also dig into your state data. And I'd encourage you to think about the information that's shared, the snapshot of how infants and toddlers and families are faring. Think about questions you might have. Think about how you might be able to use this resource to help you with your policy in your state and to also talk with other colleagues. I think with that, we can move to the next slide. And Dr. Jones-Taylor, the floor is yours.
Oh, thank you so much, Allison, and thank you to everyone at NCSL. It's been, it's just such an honor to be able to speak with you all. This wasn't in my bio that Allison shared, but I was the founding commissioner of early childhood for the state of Connecticut. And I know how critical those relationships are with our state legislators, how making sure that you all have the information you need to do best by young children and families is critical in the success of any state leader. So it's truly an honor. You guys were my good partners back in Connecticut, those of you in the state legislature in Connecticut. So the past, I'm going to talk to you today, as Allison said, about economic or the racial disparities in health equity that we see across the country. The past year has laid bare what many of us already knew, that too many families in America lack economic resources required to meet their children's basic needs. Needs like food, clothing, housing, period supplies, and diapers are frequently out of reach for caregivers with low and poverty level incomes, particularly those who are struggling with job loss and difficulty paying the rent. Next slide, please. COVID has, of course, deepened these issues, right? You all are seeing this firsthand in states. The data shows that income loss, financial difficulties, and material hardship, including loss of childcare, are concentrated in households with young children. Families now are facing new stressors as they supervise online learning while also caring for their young children. And those are the lucky ones, of course, who can work from home or who haven't lost their jobs in the face of COVID. And it should surprise no one that historically marginalized Black, Latinx, and Indigenous families, including middle and upper income households, are harder hit than most. This pandemic has widened and deepened the inequality gap in our country. From higher coronavirus infection and mortality rates to unemployment, healthcare, and childcare, communities of color are struggling this year in nearly every way imaginable. But even in the darkest moments, there remain glimmers of hope. Organizations across the country are working tirelessly to help parents meet basic needs. And I know all of you in state legislators are doing the same. And that, of course, includes 0 to 3, where I'm honored to serve as the Chief Policy Officer. 0 to 3, for those of you who don't know, is the country's leading nonprofit dedicated to ensuring that every baby and toddler has a strong start in life. A mission that's grown even more complicated and essential this year. Over the past few months, I've been lucky enough to work with a dedicated group of researchers out of the University of Oregon as they've put together what they call the Rapid Assessment of Pandemic Impact on Development Early Childhood Survey, or as most people prefer to call it, the Rapid EC Survey. And this team has been tracking the devastating impact that COVID has had on families, many of whom were struggling long before the virus reached our shores. The data shows that income loss, financial difficulties, and material hardships, including loss of childcare, are unequally distributed across households with young children. And families now are facing new stressors as they supervise online learning, as I've already said. And as this stress persists over time, it can undermine foundational brain development on which all later learning will rest. Next slide, please. So a few years ago, our team at 0 to 3 determined that we needed to bridge the gap between science and policy by synthesizing both national and local data, state level data, on the well-being of America's babies. There had never been a comprehensive state-by-state look at the impact a baby's birthplace had on their future. And surprise, surprise, we found that the state where a baby is born and raised during their first few years of life makes a huge difference in their well-being and their future. To take it a step further, this year's yearbook, the State of Baby's yearbook, focused especially on racial and income disparities across the country. And we confirmed what many have long known, that Black and brown babies disproportionately start at a major disadvantage no matter which state in the United States they are born. Next slide, please. Even before the pandemic hit, we had intended to make equity a major focus of the 2020 yearbook. More than half of America's babies are children of color, and 2 of every 5 infants and toddlers live in families with low income. But COVID-19 made that focus even more crucial. We heard stories every day from Black and Brown families and families with low incomes across the country who are struggling to keep their heads above water. Families are being forced to choose between going back to work and taking care of children and family members at home. Families who are seeing their loved ones disproportionately affected by the virus, living in viral hotbeds and dying at disproportionately higher rates. When we dove into the numbers, we saw the data foretold who the pandemic would hurt most. We saw that Black and Brown infants and toddlers are more likely to be poor, more likely to be born too soon or too small, more likely to live in environments that challenge their family's security, like crowded housing, and more likely to lack access to preventative health care. We saw an unmitigated crisis that affects babies and families in every single state in our country, with long-lasting effects throughout their lives. But we also saw that when we confront the data head-on, when we craft policy solutions that explicitly acknowledge and address these inequities, we can build a path toward a better future. Next slide, please. So as policymakers set their agendas, science tells us what must rise to the top. The greatest opportunity to influence a child's success begins early, when our brains are growing faster than at any later point in life. We know in the first 3 years of life, or the first year of life, a child's brain is developing 1 million new neural connections every second. So it's really important to keep that in mind. All families want to give their children a strong start in life, but our policies have not kept up with the reality of parenting today. The challenges that families with young children face, or the detrimental factors that rob many children of an equitable opportunity to reach their potential. So when we established the State of Babies Yearbook, we knew we wanted to measure progress across the three domains of our policy framework, which we've had for over 20 years. And those are good health, strong families, and positive early learning experiences. Each of our nearly 60 indicators on the well-being of America's babies fits into one of those 3 domains, providing us with a map of what we need to do to lift our children up. In 0 to 3's policy framework, grounded in the science of early childhood development, promotes support for infants and toddlers' healthy development in those 3 domains that I already said. The State of Babies Yearbook 2020 uses this framework that tells us what all babies need to thrive. The yearbook bridges the gap between science and policy with national and state-by-state data on the well-being of America's babies. And the 2020 edition of the yearbook, along with issue-based briefs, adds to the ability to see the babies behind the averages through an in-depth look into the substantial disparities and inequities among babies and families when examined by race and ethnicity, income, and geographic settings. So looking at urbanicity compared to rural settings. This year's yearbook continues to use a transparent ranking process to group states in one of 4 tiers to provide a quick snapshot of how states compare on the selected indicators and domains. These tiers represent 4 groupings of states that are approximately equal in size and ordered from the highest to lowest performing. And the 2021 yearbook will include some additional indicators and continue to focus on policies we know are important to babies' well-being, particularly in the wake of the COVID-19 pandemic, such as the percentage of babies and families with parents who are disconnected from work and whether they have a medical home. It is our hope that policymakers and advocates in the states use the yearbook to really see their babies and focus on the children and families behind the numbers using the extensive data we provide this year. In particular, communities can look at the data on subgroups together to forge a common understanding from which to start the conversation and actions that promote equity across equity of access to the ingredients that all babies need to thrive. Next slide, please. So let's discuss the one that many might find most relevant this year, good health. It's common sense. Physically and emotionally healthy babies are more likely to become healthy, stable, and successful adults, right? Good nutrition, nurturing relationships with parents and caregivers, and high quality medical care all support sound bodies and minds, influencing all areas of a child's development. But the State of Babies Yearbook shows wide variations in babies' health outcomes and their families' access to care. Next slide, please. Though the proportion of infants and toddlers receiving well child visits is relatively high, and there has been incremental expansion of Medicaid coverage to support families, there remain gross disparities, particularly for Black families. And maternal and infant health outcomes, including maternal and infant mortality, food insecurity, low birth weight, and prematurity. Nationally, the rate of late or no prenatal care is 6.2%. However, 7.7% of Latinx women and 9.9% or nearly 10% of Black women get late or no prenatal care. And mothers who receive late care during or after the third trimester of pregnancy are more likely to have babies with health problems. And mothers who do not receive any prenatal care are 3 times more likely to have a low birth weight baby. And infant mortality is 5 times greater. So this is a very important number to track. Children are much more likely to die during the first year of life than they are at older ages. And high infant mortality can indicate underlying systemic problems, such as poor access to prenatal care, violent neighborhoods, or inadequate child supervision. It can also point to other social inequities, for example, in access to health care or safe places to play, or exposure to environmental toxins. Among infants, the leading causes of death include congenital and chromosomal abnormalities, problems related to short gestation and low birth weight, as well as sudden infant death syndrome. About half of the difference between infant mortality rates for Black babies and white babies can be attributed to causes related to the higher rates of preterm births among Black women. Just think about that. Overall, 6 in 1,000 babies born in America won't survive their first birthday. But for Black babies, it's actually 11 in 1,000, almost double that national average. And rates are somewhat lower, but also concerning for Native or Indigenous babies at 8 in 1,000. Research shows us that infants and toddlers with dependable access to health coverage are more likely than their peers to see a doctor regularly and receive preventative health care and treatments. Routine checkups and preventative care like vaccinations and screenings help prevent more costly, harmful health issues as children get older. Nearly half of children under age 3 receive medical coverage through Medicaid, and those covered have better long-term health, educational, and employment outcomes than those who are uninsured. And health insurance is a family affair. If a parent is insured, children are more likely to be insured as well. A significant policy win in the past few years is the expansion of Medicaid, which has improved parents' access to care and has been associated with lower rates of infant mortality in states with expanded access. And finally, a quiet public health crisis has been building in our country for decades and is now receiving long overdue attention. And this is the exceptionally high rates of pregnancy and childbirth-related deaths, or maternal mortality, and pregnancy and childbirth-related health disorders and complications, or maternal morbidity. These data, which put the United States in an unenviable position relative to our international peers, are overwhelmingly driven by greatly elevated rates among Black women for reasons we will explore more deeply as we continue. And you'll hear from Kyan as well, I believe. Maternal mortality occurs at rates of 17 deaths for every 100,000 live births, but maternal mortality rates among Black women, we heard this earlier today, is 40 per 100,000 live births, more than double the national average. Next slide, please. So what causes these disparities? Women of color experience an exceptional number of stressful experiences that threaten their health. Research constantly and consistently finds a deep-seated relationship between the stress associated with racism and socioeconomic disadvantage on the one hand, and health challenges on the other. At both an interpersonal level and as reflected in discriminatory policies throughout US history, a structural level, racism has blocked opportunity for well-being among people of color. Excuse me. Families of color have always been resilient in the face of adversity, but the impacts of historical policy decisions and the chronic stresses of disrespect persist today. Black women can experience the daily emotional stress of racism well before some become mothers, accumulating wear and tear on their health, referred to as weathering, substantially in excess of that of their white counterparts. And looking at mothers and babies, particularly Black women's lifelong exposure to the interpersonal discrimination has been identified as an independent risk factor for preterm births and infant mortality. So this means regardless of your income, If you are a Black woman in this country, that is its own risk factor for your child's safety and well-being after birth. In addition, and your own well-being, of course. In addition to racism, Black women and their families disproportionately experience risks associated with poverty, including poor quality and unstable housing, exposure to environmental toxins, interpersonal and neighborhood violence, along with inadequate resources. The direct effect of these circumstances, as well as the stress they create, threaten maternal and child well-being beginning prenatally. And the history of racism in this country includes discriminatory practices intended to exclude Black and other marginalized women from appropriate health care or to coerce them into unwanted medical procedures. This history, together with a broader legacy of mistreatment of people of color by the healthcare system, has influenced a still pervasive distrust of the medical establishment among racial minority women of color. These circumstances likely account for some portion of the disparity in receiving timely prenatal care. Indeed, in a national poll, nearly 1/3 of Black Americans reported they had personally experienced racial discrimination. I know this is one of the polls we saw earlier today during a visit with a healthcare provider. And 22% said they had avoided getting care because they were wary of discrimination. So the very act of being fearful of racism is preventing people from going in and getting care. It's a very real fear and threat. So what does this look like in practice? So for Anna Akins, this translated to her sitting, and this is a family that we've worked with through our Strolling Thunder campaign. For Anna Akins, this translated to her sitting in at least 8 different doctors' waiting rooms in Louisiana for over 9 months, trying to get her newborn son's condition diagnosed while he spent his days coughing and wheezing with undiagnosed allergies and no answers. She spent hours talking with doctors who questioned her about her mental state, asked if she was on drugs, and yelled at her when she became more persistent in pushing for her son's diagnosis. Her son's diagnosis, which ended up being asthma and an allergy to dairy, wheat, and egg, it took 9 months, during which time she felt she wasn't taken seriously as a mother and actually was being discriminated against. Anna's story is not out of the norm, and she shared this story on Capitol Hill with us a few years ago as part of our Strolling Thunder initiative I mentioned a minute ago. A recent Kaiser Family Foundation poll showed that 1 in 6 Black adults say they have experienced unfair treatment while getting care. Meanwhile, a very small share of white adults say they've experienced this type of treatment. Slide 9, please. And COVID-19 has only exacerbated these experiences. We know that Black, Latinx, and Indigenous people are disproportionately likely to become infected and die from COVID-19. Native or Indigenous and Latinx people contract COVID-19 at almost 3 times the rate for white people. And Black people die at a rate nearly twice as high as white people. Reasons include an array of interlocking contributing factors: lack of access to healthcare, often stemming from being more likely to work in low-paying jobs that are less likely to provide health insurance, a greater likelihood of underlying conditions, and a greater likelihood of working in jobs considered to be essential while most of the country is shut down. Babies also have been affected. They do not put their birth and development on hold, right? Meeting their health needs has become more complicated, though, even as their environments become more stressful. And problems from young children and their parents, including difficulties surrounding prenatal care and giving birth. The problems of pregnant women having to give birth alone with partners or supporters such as doulas shut out of delivery rooms were among the first signs of the collateral effects in a health system overwhelmed by COVID-19. Women needing prenatal care also faced obstacles as obstetrical care providers moved to creative practices, including telehealth visits, self-monitoring, and even curbside monitoring. These moves mean women with low income are more likely to be disadvantaged as they seek care. They do not have and cannot afford the technology required to engage in and benefit from some of these strategies. In addition, women with low income and women of color are more likely to have underlying conditions that make their pregnancy high risk and to have difficulty accessing care even pre-COVID, further reducing their likelihood of receiving adequate care in the pandemic. And as the pandemic wore on, another concern for pregnant women has emerged, heightening the urgency for ensuring access to prenatal care. The Center for Disease Control, or the CDC, warns that pregnant women are at a higher or an increased risk for severe illness from COVID-19 and for admission to intensive care. Women of color, particularly Latinx women, appear to be disproportionately affected. Sorry, I just lost my space. COVID-19 has also led to a drop in access to preventative care for children. No other system has the same consistent and positive connection to families and their young children, or stands to make the kind of broad-scale influence to our collective prosperity. It presents a way to meet the unique needs of our communities by meeting them where they are. And yet, we are seeing an alarming decrease in access. According to reports from early in the pandemic, fewer families with young children were seeing their primary care practitioners, and vaccination rates and well child visits have dropped. Childhood vaccination rates have come up from their low early in the pandemic, but still are well below pre-pandemic levels. And this lag could leave young children at risk for other diseases. The resulting toll on pediatric care could create access problems post-COVID as well, as providers are facing closing their doors for good. This crisis could be particularly acute for young children, where 44% are covered by Medicaid and the Children's Health Insurance Program, or CHIP. In our Healthy Steps program, which is something that 0 to 3 runs, we have not seen this trend though. Child development experts, known as Healthy Steps specialists, who join the pediatric practice are able to reassure families and ameliorate their very real fears about coming to the doctor amid the pandemic. And at our Duke Children's Primary Care site in North Carolina, the Healthy Steps specialists called every one of our 200 families to make sure they did not miss their appointments. And now they are more up to date on well care than before. So great success. Next slide, please. No single strategy will be sufficient to achieve racial equity in preconception and prenatal care and the outcomes they influence. Instead, attention must be given on multiple fronts if we are to measurably improve outcomes, which have become a systemic barrier to the success of our infants and toddlers. That's why it's so important for all of us to fight for stronger policies on every level that address healthcare access and affordability, food security and nutrition, maternal and child health, and infant and early childhood mental health. And a strong example exists in the Project Hope Consortium. So Project Hope, which stands for Harnessing Opportunity for Positive, Equitable Early Childhood Development, builds capacity of local communities and coalitions, state leaders, and cross-sector state teams to prevent social adversities in early childhood and promote child well-being. Through a 6-month leadership institute beginning in 2018, selected states developed an application portfolio to be a focal point, a focal state to work on system building and practice change at the community level. Digging into their own disaggregated data allowed state leaders to see whether racial inequities exist. And each state was tasked with connecting community partners to hear the multiple family stories behind the data, which is so critical to do, real life stories. I could go on, but I want to be mindful of time, but I will say this. Alabama, which was chosen as a Project Hope focal state, chose to target 2 counties already highlighted in an ongoing statewide initiative to reduce infant mortality rates. A team consisting of staff from health, mental health, and child and family agencies mapped data to the sub-county level on indicators such as infant mortality and health and well-being, and brought them even closer to the people behind the numbers. Focus groups or beneficiary voice meetings with members of the community yielded more thorough insights to the daily changes communities were facing, getting even more proximate to the problems. I'm going to go ahead and, well, I think I have time. Am I doing okay, Allison, for 2 more examples? Okay, good. Our Colorado Think Babies state partners, and just so you know, State of Babies is an initiative of Think Babies, which is our broad campaign to get, you got it, legislators and policymakers to think babies whenever they're creating policy. And we have state partners, including in Colorado. And so our Colorado Think Babies partner has also been conducting listening sessions throughout the state about equity in birthing, and with the goal of reducing infant and toddler mortality. These listening sessions explore what participants think is working well and what challenges still pose a barrier to healthy birthing. Listening sessions are being promoted on social media, and strategic partners are strengthening outreach to help encourage participation. And lessons learned will inform 2021 and 2022 statewide legislation, ensuring policies are deeply rooted in community voice. And finally, California, my home state, California's new Dignity in Pregnancy and Childbirth Act requires implicit bias training for all healthcare professionals working in prenatal services. The bill also contains state reporting requirements to track outcomes for pregnant women and mandates hospitals and birth centers to provide information on how patients can file discrimination complaints. This new legislation makes California the first state in the United States to require implicit bias training for prenatal or perinatal healthcare professionals. A major lesson we have gleaned from these efforts is that racial equity and early childhood systems cannot be treated as separate issues. Speaking to families and keeping their voices at the center of this project brought the teams closer to challenges and service needs of families in Alabama, in California, and in Colorado. And this is not just about new program funding. Continued goals to achieve equity for young children and families are to promote optimal health and well-being, prevent and mitigate early childhood adversities, improve adverse social settings to reduce racial, ethnic, geographic, and economic inequalities, shift or realign aspects of systems to increase access to opportunities in communities, and engage community members to create that feedback loop. So next slide, please. One thing I want to leave you all with is a question around something that was raised with this issue of being proximate. And I really appreciate that you all have been thinking about how you can personalize the data. And certainly if you look through the State of Babies Yearbook, there is a lot of data, and it's important to have real life stories and really understand what's happening at the community level so you can think about these policy solutions that I just mentioned. One thing I do want to challenge you all to think about as you move forward through this 6-part series is how you are thinking at the community level and in your states about engaging families and Black families in particular. And I really want to challenge you to go beyond this profile of Jamal, which I understand you want to personalize the data, as I said, but I do worry that in creating this story, this singular story of one Black child, you have missed an opportunity to go out and see other families and real life children who represent a more complex story than the one that is presented by Jamal. I worry that what you have in that story, which I think is well intended, and going back, I love being able to root this in history. But my fear is that you have in that a 2-dimensional caricature, if you will, of what it is to be a 5-year-old Black boy in this country. There are no protective factors in Jamal's story. And he has had every negative thing you can imagine happen to a Black child without all the other richness that acts as buffering. So I do want to challenge you all to think about how you are engaging with that one singular story throughout this session. And I want to encourage you to reach out to folks in your community who can give you a real life picture of what it's like to be a Black child in this country, a Black family in this country. That said, the data provided by the State of Babies Yearbook makes it clear that our nation has been complacent for too long and has looked the other way too often when families have struggled with persistent challenges. Our babies deserve more than what they're giving them. And you at NCSL and you and all of your state legislators have an incredible opportunity to change the trajectory of children in this country and make sure that we no longer have these gaping racial disparities. There are obviously an injustice for people in this country, but they're also bad for this nation. If we have half of all children being children of color and so many of them face these disparities, the entire country will not thrive and will not be where we need to be if we leave any of these children behind and these families behind. Thank you so much. I will hand it over to you now, Allison.
Thank you, Myra. That was wonderful. I really appreciate that. I think what we're going to do right now, if anyone has a burning question to add in the chat, please feel free. But our first breakout session, and Riley, you can move to the next slide if you don't mind. Our first breakout session is kind of going to give us an opportunity to think through in a smaller group what we just heard from Dr. Jones-Taylor and kind of formulate some other questions we might have. So we're going to have 5 minutes in breakout rooms with some NCSL staff helping to facilitate the conversation. You can see on your screen sort of our prompts, you know, what stood out, what were your aha moments, what do you want to clarify and learn more about? And so we're going to break into groups for 5 minutes and do a very quick round of introductions so you know who all is in the room. And unless someone is very eager to be the report out person, which would be fine if you want to be the report out person, consider, you know, about a minute highlight of what you all talked about. If no one wants to volunteer for that role, the person who has the first initial of their first name closest to the start of the alphabet would be the report out person. So for instance, if your name were Allison, chances are you would be the one taking about a minute to highlight what you talk about in your small groups. Questions? And if not, I think Shannon is going to, well, I should pause and say, are there questions? Hearing or seeing none. Shannon, do you want to move people to their rooms, please? I see you all disappearing.
COVID is bringing, right? That's kind of telling the story of the amplification of what's happening. So that came out. And then also just understanding that and hearing the data again and getting it strengthened and seeing it from different angles and is really helping to strengthen the story and the narrative of how we can frame this conversation in our home legislature when we're trying to work policies, which was helpful about the aha moments. And then questions coming forward really around trying to dive deeper and help us get that first year life of impact, so we can talk about, you know, that very early benefit of making sure that the system is strong and in place to support all of our children, and our children can thrive the best, and making sure that there's not a false choice out there that is around making, I mean, part of the tensions that we talked about that happen when we try to move policy is around the is what role does the state play and the government play in childhood policy versus what should be done in the home. And we talked about how the data really helps frame that narrative, so that we're talking around the data and why we would be focusing on a particular group of families and folks. And so when we're talking about Black families and the outcomes and the health outcomes, we can have that data that helps explain why we're doing what we're doing, and then talk about really around how we're providing true access and quality of care, and what does that look like and mean, so that families can make those choices in their homes, right? They can't do that if there's not really a true system of access and support and quality to make that happen.
That's great. Thank you. Thank you for sharing, Rep. Callan. I think, Bethany, did I hear your voice trying to chime in? Did I make that up? Green.
I'm just trying to get it out of the way. So we talked a little bit about what was mentioned in California due to statewide implicit bias training. There's a specific New York hospital system that has implemented training, and they made a public declaration about this being a problem and public health problem, and how encouraging, I guess, it is to have the ground level also working to implement that kind of training. We talked a little bit about the state data and the story about the mother who struggled to get her child diagnosed. I think that is a story that just so many people can resonate with, and it was about there that we got our 5-minute conflict.
Awesome. Thank you. If anyone else, if we have another maybe volunteer, and then in the interest of time, we might not all get to share, but we can move on to hear from Kine and then have some time to open it up for full conversation. Any other volunteers? One more volunteer to share a little?
Hi, Allison. This is Senator Dinah Sykes from Kansas, and our group, someone brought up another NCSL event that you had a demographer who was talking about the browning of America, and tying that in and really just, you know, focusing, if we don't focus on the population mathematically, we're in a downward trajectory because we're not focusing on any of our children if we're not focusing. So I think that was a different thing that I wasn't hearing from the other groups. And I would like to say, I was reaching out to my colleague in Kansas, and we were not familiar with Project Hope or the Think Baby. So we would like more information on those. So that's just me adding it.
I just muted myself. I appreciate that. Myra, I wonder if you have any comments about Project Hope or Think Babies real fast to fill in, or if we should do that later, whatever's more convenient for you.
I'm happy. So Project Hope Consortium, and of course I'm thinking about who is actually sponsoring this, and I apologize, I don't have it on in my notes, but it's really thinking about both state and local level coalition building to think about what families need, what young children need in the earliest years of life. And what's really great about it is it's these cross-sector teams. So it's not just the early childhood folks, it's you have health people, you have really this great cross-section of all the things that we know young children and families need to thrive in their earliest years. So why don't I just shoot a little chat just to make sure I have that. And then I just put in the chat, Think Babies. So that is our initiative. It's a national initiative we've been doing now for 4 years, and it's really incredible the kind of gains that we've seen in state. So it's both a state and a federal initiative. Initially, the first year it was just thinking about what was happening at the federal level, and we realized there was so much action happening in states. We wanted to support that and hold that up. And so we're in Colorado, Washington, Georgia, North Carolina, and Rhode Island. I think I got them all, and New Jersey. I think I got them all. And it started off really just thinking about some key issues. So childcare, paid family leave, health and nutrition, and it has now expanded to early Head Start. Really many things that we've heard from states that they want to focus on, pushing at the state level to get some major wins there. And then of course at the federal level, thinking about what we need around paid leave and childcare in particular. So happy to share more about that. I don't want to hog up all the time.
Great, thank you. And I see thank you, Donna, for adding to the chat. If other people want to share what their group talked about, we'd love to see that. And I think for now, Riley, if you want to move ahead to the next slide, I think to try to keep us on time, I'm going to turn things over now to Kainwen from NCSL's education program to share some information. You see right there on her slide deck, what she's going to share with us. So Kain, the floor is yours.
Hi, thank you, Allison. I'm Kain Wen, Senior Policy Specialist in the Health Program here at NCSL. And as she mentioned earlier, I specialize in maternal and child health policy. And my team frequently collaborates with the early care and education team just because of how our issues overlap. Today, I'll be sharing recent federal and late state legislative trends to provide you with policy options and examples of how states are addressing racial disparities in maternal and infant outcomes, particularly around mortality. Before I get into the examples, I just want to note that there are many pieces of legislation aimed at reducing maternal and infant mortality, some of which may also affect disparities, but the ones I'm highlighting today do refer specifically to racial disparities in the text or in the sponsor's intent. So next slide, please. First, we'll look at federal action, then go into state examples, and I'll close by highlighting some helpful resources. Next. In the last couple of years, we've seen a federal bill passed that expanded CDC support for state and tribal maternal mortality review committees. These are multidisciplinary committees in cities and states that collect, analyze, and report data related to pregnancy-related deaths in order to make recommendations to prevent future deaths. For context, at least 40 states have maternal mortality review committees. This bill specifically calls out identifying and reducing disparities. Examples of bipartisan bills that have been introduced at the federal level include a bill to reauthorize the Healthy Start program, which supports interventions to improve women's health before, during, and after pregnancy, and requires administrators to, or would require administrators to consider communities with high rates of infant mortality when awarding grants. The Excellence in Maternal Health Act of 2019 aims to improve maternal and perinatal health care quality and training of healthcare professionals to reduce or prevent discrimination. Additionally, the Moms Matter Act would award grants to support innovative models of maternity care, including group prenatal care and postnatal care designed to reduce racial and ethnic disparities. Next. But states have really been at the forefront of legislation in this area. As I go over these examples, please feel free to share others that you've seen or ones you may have from your own state in the chat box. I've organized these into sort of prenatal or perinatal care, maternal mortality, and infant mortality, but many of these policies address multiple areas and populations. So one way that states have addressed disparities in prenatal and perinatal care is through quality collaboratives. Perinatal quality collaboratives, or PQCs, identify healthcare processes that need to be improved and use quality improvement principles to address gaps in maternal and infant care. PQCs often aim to reduce preterm births, severe pregnancy complications related to high blood pressure and hemorrhage, cesarean births among low-risk women, and disparities by race and geography. Almost all states have some form of PQC in place or in development. But Illinois recently expanded the scope of its PQC to explicitly include developing an initiative to reduce peripartum racial and ethnic disparities. For example, the bill references education for providers around managing severe maternal hypertension and hemorrhage, as well as addresses implicit bias in healthcare. And Louisiana created the Healthy Moms, Healthy Babies Advisory Council within the Department of Health. This bill provides that the council, made up of experts and stakeholders committed to addressing racial and ethnic disparities in maternal care and health outcomes, support the state's PQC to incorporate a community engaged approach to preventing maternal mortality and morbidity. Next. This leads us into additional options around reducing disparities in maternal mortality. Alabama recognized cardiovascular disease as a leading cause of maternal deaths and highlighted the racial disparities in heart disease among women in their state. As Dr. Jones-Taylor noted, California passed the Dignity in Pregnancy and Childbirth Act, requiring maternal care providers in hospitals and birth centers receive implicit bias training. Delaware and Georgia requested studies into ways to reduce maternal mortality overall and to reduce racial disparities. Delaware specifically requested studying extending Medicaid coverage from the 60 days that's required by Medicaid to 1 year postpartum. The CDC cites data indicating that 1/3 of pregnancy-related deaths occur between 1 week and 1 year post-delivery. And because Medicaid covers a large share of births among racial and ethnic minority groups, Medicaid health plans are uniquely positioned to identify and address disparities in health outcomes. In 2019, Georgia established the House Study Committee on Maternal Mortality, requiring certain representation from African-American female legislators to provide recommendations to reduce maternal mortality and address disparities. The committee released its recommendations at the beginning of 2020, which included extending postpartum Medicaid coverage. This summer, the Georgia legislature unanimously passed a bill extending coverage to 6 months postpartum. I also want to note that during the current national emergency due to the pandemic, states receiving certain increased Federal CARES Act funding may not disenroll valid Medicaid enrollees, which effectively keeps pregnant women covered by Medicaid beyond the 60 days, at least for the duration of the national emergency. And finally, on this slide, Vermont made revisions to their maternal mortality review panel, as it's called in their state, related to its membership, access to information, and requiring the panel to consider health disparities and social determinants of health, including race and ethnicity, in its maternal death reviews. Next. States have also formed review teams for infant or child death. Indiana established fetal infant mortality review teams, which are local teams supported by a statewide coordinator and requires them to be multidisciplinary and culturally diverse. New Jersey directed its Child Fatality and Near Fatality Review Board to study racial and ethnic disparities contributing to infant mortality and address disparities in breastfeeding. Next. These additional policy examples address both maternal and infant mortality. Illinois created the Task Force on Infant and Maternal Mortality among African Americans to study and establish best practices to decrease disparities in their state. Indiana approved doula reimbursement by the state's Medicaid programs. Doulas, in case you're not familiar, are trained professionals who provide physical, emotional, and informational support to mothers before, during, and after childbirth. Pilot programs and some other studies show that support from doulas is linked to better health outcomes, such as lower C-section rates, lower chance of low birth weight babies, fewer complications, and higher chance of initiating breastfeeding. This bill aimed to ensure that healthcare practitioners listen to and address women of color's concerns and preferences throughout the birthing process by having a doula to support and advocate for her. Louisiana requested the state health department to immediately address racial disparities in maternal and child health outcomes, such as through increasing access to home visiting, doulas, healthcare professional diversity sensitivity training, and working with community and religious partners. It also requests a summary report of these actions. And Maryland required the state's cultural and linguistic healthcare professional competency program to establish and provide evidence-based implicit bias training for perinatal healthcare professionals. Next. I also wanted to include just a couple examples of how states have addressed COVID disparities through legislative action this year. In June, Louisiana passed a resolution requesting that the Department of Health study and report on the matter of racial disparities in COVID death rates, asking them to engage and solicit input from the COVID-19 Health Equity Task Force, which was formed by the governor in April. This resolution cites the one I mentioned earlier in Louisiana related to racial disparities in maternal and child health outcomes. And in July, Vermont's Coronavirus Relief Fund appropriations bill included funding to address COVID-19 health disparities through subgrants to community organizations to engage with specific populations such as by race or ethnicity, more likely to experience adverse outcomes from COVID. These subgrants may assess and address needs around disease prevention education, access to testing and treatment, and safely meeting basic needs during the pandemic. So that was a really quick and fast overview of trends we've been tracking, and you'll be able to review the examples in more detail at your convenience when you get the slides. But I hope this was helpful in providing some examples of recent policy actions in this area. And please feel free to reach out to me if you'd like any further information. Next slide. Here are some NCSL and other resources on efforts to reduce maternal and infant health disparities. We have a searchable database that tracks 14 categories of maternal and child health enacted state legislation, including maternal and infant mortality. NCSL is also preparing to revamp and launch new resources around health disparities legislation, so please stay tuned for that soon. And I also wanted to highlight that the health program has a maternal and child health fellows program modeled after your successful program. So you can find more information about the fellows and slides from former meetings and sessions on the webpage there. That is all I have. Thank you so much.
Thank you so much, Kyne. That was excellent. If anyone has any legislative examples that they'd like to share, as Jenny just said, I would encourage you to pop it in the chat. And while you're thinking about things that you might want to talk about as a larger group, I'm going to ask Riley to advance to the next slide. We're going to just, that slide lies a little bit. Instead of 6, we're going to go ahead and take 5 minutes. We're going to go back into the same groups we were in before, so we won't need to reintroduce ourselves to one another. I know there are a few people who have ducked off the line, but during this breakout over the next 5 minutes, reflecting now on what we've heard from Kine and what we've heard from Dr. Jones-Taylor, think about what barriers you face at the state and local level, and think about the data that would help you better tell your story and build public will. So hopefully this can also be a continuation of the conversation you just had. We'll come back into this full group after 5 minutes, and I would like if maybe 2 or 3 people would volunteer to say what their group talked about. Again, if you want to volunteer for that role, you can. Otherwise, this time we're going to mix it up. So if your last name starts earliest in the alphabet, you will be the one to share out, which essentially means if your last name is Zicafus, you would not be reporting out right now. So Shannon's going to break us into our rooms, and then we'll open it up for full dialogue once you all come back to this main room. I hope that sounds good to everyone. On the topic of paid leave, I actually just wrote a piece on the topic, so I'm going to drop that into the chat in case anyone's interested in learning a bit more about state action related to paid leave. And now that Colorado, Rep. Lantin, I saw your chat, as a Coloradan, I'm excited about that and interested in seeing what's going to happen next. So I'm also planning on writing a blog to talk about that sort of win, and also push out the brief some more. So hopefully that will be helpful to those on the line. I wonder if we have maybe 1 or 2 volunteers that just want to quickly share out a little bit about what they talked about. And then honestly, at this point, we really, if you have other questions in general, while we have Kine and Dr. Jones-Taylor on the phone, I would invite you to ask any questions. So.
Okay, I'll jump in. This is Michael Dembrow from Oregon. And our group, in terms of data, having data that shows the cost savings from different strategies would be very helpful. Some clarity on which states have been able to expand their Medicaid to cover all children and women, mothers before birth and for a period of time after birth. And where that can be very challenging is with undocumented families, the children of undocumented workers. That's something we haven't really talked about, but that's probably a special population for focus and a challenge, both in terms of their ability to overcome the fear of coming forward and requesting those benefits, as well as the state's attitude towards providing them with those benefits. Thank you. Thank you for this session.
Thank you for that feedback. I don't know, Myra or Kine, if you have any comments in response to that. States expanded Medicaid. I know, Kine, you probably, or at least some of your colleagues track that. I wonder if it's something we can share after the fact as a resource.
Let me just unmute myself. Yes, I'm happy to follow up with you to share a little more information about that. But pregnancy and delivery is a time in life that most women do find themselves covered by Medicaid or CHIP, just because most states have made it so that as many as possible births are being insured. There's still some who are falling outside of that, but at least during that period, we've seen most states do a pretty good, offer coverage to ensure that end.
And does that include the children of undocumented mothers generally?
I actually don't know that information, so I don't want to give you bad information. I'll look into it though, for sure.
Okay. Yeah, so we'll get back to you, Senator, and I guess if others are interested, we can send something out to the full group.
Our
Melissa?
state does extend that benefit, but it was hard fought, to be honest.
So I see Melissa popped into the chat some examples. Hopefully you all see I was expecting results back from a report that will include race equity issues and will set the stage for early childhood moving forward. Well, that's great. I'm assuming Rep. Bergen, that was your update. That's nice to hear. And Kansas has established a caucus, including both Republican and Democratic early childhood issues. Well, I know that. I'm glad you guys are still meeting, and NCSL would love to be part of the work that you all are doing. That was not for my benefit, I realize. I wonder if we have anyone else who wants to share out any information and or if we have any questions. I know I told you we'd go about 90 minutes and we're 3 minutes short of that. So I'm gonna say we're gonna go a few minutes over, not by much, but if anyone has any questions now, do feel free to unmute and ask the questions or place them in the chat. And I've got just a few more pieces of information to share with you as we begin to wrap up. But questions from anyone? No? Well, that's perfectly fine. I can keep my promise and stay on time. So if you have additional questions that come up, do feel free to reach out, send an email. If I can't answer it, which there's a good likelihood I wouldn't be able to, but I work with really smart people and have contacts that are really smart. And so we have these wonderful presenters that were with us today. So we will get answers and share it back with you, most certainly. I want to say thank you. Thank you to everyone on the line for participating in a robust conversation today. I hope you all had an opportunity to process and think about things a little differently than you have in the past, that you'd have appreciated this time. Thank you so much, Dr. Jones-Taylor. Thank you, Kine. We really appreciate both of you making the time to present to legislators and staff on these important topics. And it would not be an NCSL meeting without putting a plea in for you to give us some feedback. Let us know, how did we do? Jenny just shared a link for a Survey Monkey. It's also on the screen in front of you. But if you could just it probably won't take you more than 3 minutes, honestly, to give us a little feedback about how the session went, what else you might like to learn. We really do read these and we are trying to be as responsive and adaptive as possible so we can be the best organization for you all. Mark your calendar. I hope everyone will be able to join us. The next session is going to be on January 21st. It's going to be on a Friday. The reason January 22nd, excuse me. 22nd. Yep, which is a Friday the 22nd. We're moving to Fridays once the better part of you on the line are going to be in session. So it's our understanding that Fridays sometimes are a little quieter around the Capitol. So I see Senator Dembro saying, so hopefully Fridays works and you all be able to find some time to join us again, noon Eastern time. And a little bird told me we might have some really exciting presenters. So, mark it off on your calendar and stay tuned for more. I hope you all have a very healthy and happy Thanksgiving and holiday season. I know this is certainly a unique time right now, but stay safe and enjoy. And please, questions, come to us. NCSL is your organization. You are members of our organization. We feel like we're an extension of the legislature and we are here to help you. So reach out. Thank you so much, everyone. I hope you have a great afternoon.